Okay. Thank you so much for inviting me. It's really an honor to be here. I did not change the title of my talk, which means I'm charged with developing a better process for informed consent. And really, my goal in the next 20 minutes is to begin to describe practical steps in this effort to improve the process and in our effort to achieve ethical goals. And I'm expanding here on some ideas that we published in a JAMA commentary with Alan Meisel a couple of years ago. So I wanted to do something a little bit different, perhaps, which is frame this discussion around a case. This is the case of Mr. L, who's a 70-year-old man with end-stage heart failure being evaluated for a destination left ventricular assist device, or LVAD. And I've chosen this case in part to illustrate many of the challenges of informed consent, as well as opportunities for improvement. So LVADs are complex devices. Pressing the right one here. Oops. Oh, you know, these are not, we are having technical difficulties. How do I get the rest of the slide to show here? Help is on the way? Okay, we need the pieces of the slide. Sorry, guys. Well, I will, in the interim, because I know time is moving along, tell you a little bit about LVADs. These are essentially a pump connected to an external computer that does the work of the left ventricle, so pumping blood throughout the body. Obviously, very complex devices. These are high risk, so surgical mortality is somewhere between 5 and 30%, and they're also preference-sensitive procedures, right? So they involve significant trade-offs affecting quality and length of life. Yeah, you want to try again? There are multiple lines of text that come actually on each slide. So it was working when I tested it this morning, so I'm not sure. Okay.
Sorry.
I hope not. Did we just see Yael Schenker PowerPoint? There we go. Perfect. I didn't think I was being too fancy with these slides, but apparently I was. Okay, so this is just one example and a case that I've been involved with recently. I just want to sort of say at the outset that I think it's equally important, obviously, to examine and improve the process for less complex and lower risk procedures. Okay, so why is it not going now? What's that? Stay up here? I know, okay. So, you know, what are the goals of informed consent? This is something we've talked a lot about already, and I'll just share with you a metaphor that's helpful for me in thinking about this. I like to view informed consent as scaffolding. So, like scaffolding, it performs, I think, a basic safety function that is protecting patients' autonomy, helping to ensure that patients have the fundamental right to decide what is done with their bodies. And it also, you know, like scaffolding, supports the building of the cathedral. And in this case, I think the cathedral is patient-centered care. Informed consent is the platform from which we work to help ensure that patients are involved in medical decisions and that these decisions reflect their values and preferences. So there are many documented failures of informed consent, failure to achieve adequate understanding, and poor understanding can lead to medical errors. as well as receipt of preference discordant care. And I think it's worth noting that some commentators have viewed these failures as evidence that the requirements of informed consent are unrealistic, or that the concept itself is somehow flawed. Can we do better? I'm going to submit that the answer is yes, and we have some evidence to support this view. This is from a systematic review of trials to improve patient comprehension and informed consent in clinical settings. This is work I collaborated on with Alicia Fernandez and Rebecca Sudore and others that we published in Medical Decision Making in 2010. And here, trials are grouped by the type of intervention they examined, with written interventions in the first grouping, audiovisual multimedia interventions in the second, extended discussions in the third, and test feedback techniques in the final group. Within each group, studies that demonstrated improved patient comprehension was the outcome here, are in the left-hand column, and higher quality studies are indicated with darker crosshatches. And as you can see, while not uniformly positive, the majority of 44 trials included in this review demonstrated improved patient comprehension with relatively simple or straightforward interventions. This is in contrast to the Flory study looking at informed consent in research settings. So I would submit that rather than abandon the cathedral, we build a better scaffolding. And I think when we look carefully at key steps of the process, the who, when, what, and how of informed consent, we find room for simple improvements. So that's what I'd like to do with the rest of the time. Started to get a little PTSD pressing this button here. Okay, here we go. All right, so first, the who of informed consent. So traditionally, responsibility for obtaining informed consent rests with the physician who's performing the procedure. And so returning to our case for a left ventricular assist device, or LVAD, this is a cardiothoracic surgeon. And I think it's certainly important for Mr. L and his family to have the opportunity to meet the surgeon before surgery and to ask questions. But I would ask whether the surgeon is the best person to conduct the consent process. So what if, for example, she has lousy communication skills? What if, and it's likely she has a little time, and what if she simply does not enjoy talking with patients? So there are other important members of the team now involved in the consent process for LVADs. One is the LVAD nurse coordinator, who probably knows more about these devices than anyone and has more time to spend at the patient's bedside. And as of last year, CMS actually requires that a palliative care physician be involved in the process as well. When you think about it, this makes sense because a surgeon knows a lot and thinks a lot about the risks of surgery, but may not be the best person to discuss alternatives to surgery. So an analogy is something like asking an air conditioning company representative for information about ceiling fans. Palliative care clinicians, in contrast, are trained to discuss alternatives, including the alternative of not pursuing a potentially life-prolonging intervention, to think about and compare outcomes for these alternatives and to elicit patient values. So a team-based approach to informed consent requires clearly defined roles. I think involving members of the team who aren't involved in performing the procedure can help provide more balanced information, improving patient understanding, and helping to ensure that informed consent is an informed choice that reflects patient values. And I would propose that this can also be more efficient if each member of the team is charged with achieving a smaller piece of the consent process at the appropriate time. So let's talk a little bit then about timing, and this is something we've heard a lot about already, the when of informed consent. Traditionally, the consent form is signed immediately before a planned procedure. Of course, we know that signing the form is not the same thing as conducting the process, and when the entire process takes place immediately before procedure, I think we've heard about several potential downsides. One, in the case of LVADs and for many other high-risk procedures, that the patient by that point may be too sick to meaningfully participate, may lack capacity, and surrogate consent may be required. We've also talked about patients providing consent immediately before a procedure being psychologically committed to proceeding. We've heard about the example of patients who are, strapped down and in the surgical waiting room. I like to think about informed consent for colonoscopies after having completed the colon prep. Well, I don't like to think about that, but I do think about that. And so, commentators have written, and I think it's a nice way to put it, that informed consent in such situations constitutes little more than a medical Miranda warning. In contrast, if we think about starting the process in advance, there are several potential advantages. The patient may be not as sick. Multiple information sessions may be possible, and for a procedure as complex as LVAD surgery, that may be important. The patient may have more time to prepare, to engage, and to ask questions. And informed consent then becomes an informed choice rather than simply an acknowledged understanding of a treatment option that has already effectively been chosen. So I think timing matters. I've tried to illustrate here the process that may take place between introducing informed consent and signing the form. I think the nature of this workflow will vary depending on the urgency and complexity and preference-sensitive nature of a procedure. But when we talk about informed consent as a process, I think it's important that we allow time for this process to occur. So let's talk a little bit then about the what of informed consent. What do we currently focus on in our consent forms and our consent discussions? And I think the answer currently is risks, and I'd like to just illustrate that here. I've cut and pasted in 3 parts just the text of the consent form for LVADs describing the risks of the surgery. So as I mentioned, this is a high-risk operation. It's certainly appropriate for these risks to be discussed, but this overwhelming focus, I think, has several potential downsides. So one is that risks are often described in vague terms. So for example, how often do we see or hear the risks are bleeding and infection? So this applies to a destination LVAD. It also applies to a simple blood draw. As I attempted to illustrate in the previous slides, I think laundry lists of risks are overwhelming. And there's then the additional risk that patients will do what many of us do when we're confronted with fine print forms written in legalese, and that is skim them and hope for the best. And finally, I would submit that a focus on risks can be impersonal. It's not clear to what extent each risk on the laundry list will apply to you. So if the risk of surgical mortality is 30%, patients may hope that they will be in the 70%. So I'd like to propose instead a focus on outcomes, and this is something that Gretchen Schwartzy describes beautifully in her work, and something that I know Rebecca Sidori will be talking about more this afternoon. And a focus on outcomes involves thinking first about the best case scenario. So returning to our case, for Mr. L, the best case scenario may be that he survives the operation. He's able to return home and live independently for another 5 to 7 years. And then thinking about the worst case scenario. And again, this may depend on the values of the individual patient. For Mr. L, it may be that he dies during the operation, or it may be that he suffers a devastating post-surgical complication such as a stroke requiring around-the-clock care. And then finally, what is the most likely scenario for that individual patient. I haven't given you details of Mr. L's case to determine this, but suppose it's most likely that he survives the operation and is able to return home, but he's unlikely to be able to return to activities he previously enjoyed, such as sailing. We can then discuss these outcomes in light of the patient's goals. And again, these are diagrams adapted from Gretchen Schwartz's paper on how to help patients navigate high-risk scenarios. So in this diagram, we can illustrate for patients how their goals align vis-a-vis the worst case, best case, and most likely scenario. Here for LVADs, and then we can do the same for alternative therapies, in this case, maybe palliative medical therapy at home. So I think looking at and thinking about outcomes in light of goals helps to contextualize risks and may aid patients in making more informed and personal choices. And finally, I'll end briefly with the how of informed consent and talk briefly about two best communication practices, which I think we'll hear more about today. One is ask, tell, ask, and then show, don't tell. So ask, tell, ask is a variation of teach back that has been recommended in many different types of medical conversations, including discussions with seriously ill patients near the end of life and conversations to engage patients in self-management of chronic diseases. And I think it's also a useful model to think about for informed consent. And I like it because it starts with an invitation to the patient to share what they know about a procedure. What have you heard about LVADs, both inviting the patient to start the discussion and also helping to elicit any potential misunderstandings or misconceptions up front. And this, I think, structures the conversation more efficiently because the clinician can use the time to fill in these knowledge gaps or to correct misconceptions. And the final ask is framed not as a test or challenge, but rather as an opportunity for the physician to do, or clinician to do a better job explaining the next time. So I want to be sure I've done a good job of explaining things today. Can you tell me what we talked about in terms of what to expect after an LVAD? And then finally, show, don't tell. As I mentioned, these are complex devices requiring lines of fine print to describe. Why not show a picture instead? Post-surgical care and conditions are also complicated. Why not use a video or perhaps even introduce a real patient? And, you know, we've talked some about technology. I think technology is most helpful when it can help illustrate for patients what words in a consent discussion or on a consent form cannot. And I think can help enable patients to envision both treatments and their outcomes. This is something that Angelo Volandes has shown repeatedly in his work, using videos to depict both future health states and medical interventions, such as CPR. I think technology can also help engage patients in the process. I think Rebecca Sudori will be talking about her work, Prepare, using videos to engage patients in the steps of advanced care planning. And finally, technology can help connect patients with others contemplating a high-risk procedure or who have already received that type of procedure through online support groups. So in summary, I've highlighted several steps toward improving the process, thinking a bit more about the who, when, what, and how, using a team-based approach to improve the quality of information, beginning the process in advance, focusing on outcomes to help contextualize risks, and then using ask, tell, ask, and maximizing use of technology to help patients envision what they can expect from a procedure. So again, the ethical goals, both protecting patient autonomy and involving patients in these decisions about their health. And I'll end there. Thanks so much.